Hi, welcome once again to Senior Focus. I'm your host, Bill Adams, and Senior Focus is a show designed for adults over the age of about 50 or so. We come to you a couple times each month through Armstrong's Channel 20 and 100, and thank you to Greg Roten, who is Armstrong's local programming producer, and also thanks to the library system of the public library of Mahoning County in Youngstown for allowing us to use their rooms. So today we're going to be talking to someone who has been here in the past, but it's been a few years, Professor Paul Knight, who is from Glasgow in Scotland, a long way to come.
Indeed, yes, it is.
And why don't we just talk a little bit about what brought you to the Mahoning Valley this time?
Okay, well, I've actually been coming since 1985, so this is my 32nd anniversary of coming to the northeastern Ohio, and it really is a link with Dr. Chuck Wilkins at St. Elizabeth's. We've been working together over that period of time, and I usually come for about 4 or 5 days, once a year, and I assist Chuck with his education of residents and students, both from the local area and slightly further away. So it's a really enjoyable experience for me. It's something a bit different, and I've been doing it quite a long time now.
And you're the perfect person to come and help, because your background is in geriatrics. Now, I don't want to miss any of these, but I know you've been the past president of the British Geriatric Society, also the European.
That's right, yes.
Now, most recently, this is very interesting, you were appointed a member of the General Medical Council.
That's right, yes.
And could you describe what that is?
Okay, so the General Medical Council is the body in the United Kingdom which registers doctors, and it's existed for about 150 years. It has similarities to a state medical board, but it goes a bit further than that in the sense that it sanctions all undergraduate education and all postgraduate medical education in the United Kingdom. So if you're a doctor from an international doctor coming into the United Kingdom, you would need to register with the General Medical Council, and in fact for many they would need to pass an exam to get in. So there are similarities, as I was saying, with the state medical boards. So the council itself has gone through a lot of changes over the 150 years. You used to be elected and now you're appointed. There are 12 people on the council, of which 6 are medically qualified and 6 are lay people to represent the public. And that's a relatively recent change. And the methodology of you being appointed is you're actually appointed by something called the Privy Council, which sounds quite grand. This is a government body which takes recommendations after a process of interviews and so on.
Now, speaking of something that sounds grand, and it is grand, you're an officer now also. That would be an OBE, right?
Yep.
Now, and we were talking before the show, the only thing I know about the OBE or the MBE, which are awards in Great Britain, are that the Beatles received an award, but yours is slightly higher.
Yes, I suppose. I suppose you've got Sir Paul McCartney now, so he's leapfrogged me a bit. But I think it's slightly anachronistic, the award, but it's very similar to the presidential medals that are awarded in this country, and it was first put together in 1917 by King George V to recognise outstanding public achievement, and this was a way of doing that. So it was just towards the end of the First World War, and there are civil and military divisions of this. So it was a great honour. In fact, I just received the award last week on a very easy to remember date, which was the 4th of July.
Oh, okay. And that was from the Queen herself?
It was from the Queen herself, yes. They're not all done by the Queen, but I don't know whether I got special dispensation, but yes, I was lucky enough to meet the Queen.
And again, this is an award that's given for your particular service in geriatrics, is that right?
Yes, it was to do with my contribution to the healthcare of older people, yes, that's exactly correct, yes.
Well, speaking of that, speaking of healthcare for geriatric folks, we have, hopefully a lot of people out there who are like me, over 50, who may be watching. What are some things that people as they get older can do to take care of themselves better, or to try to promote a good older age?
Well, I'm over 52, and I would like to think that I practice what I preach, so that there are some things that you shouldn't do and some things which you should do more of, and I suspect nothing that I'm going to say now is going to surprise anybody. So,
but you're official, so it might.
Yeah,
take
well,
this
you never
time.
know. And I've come from a distance of more than 10 miles, which makes me an expert. So
Okay.
I think in that sense, what I would suggest is that being more active, and not just physically active, but mentally active. So I think a lot of people have difficulty putting the two of those together. So, being in a social situation, being active. Now, being active doesn't necessarily mean that you have to go to the gym.
Okay.
So my being active is playing golf. So I play golf. I gave up golf during much of my working life because I didn't have the time. But I think anything that increases your activity level is good. Don't drink too much. That doesn't, alcohol I'm talking about, but you don't need to cancel it out altogether. The odd glass of red wine or whatever your favourite tipple is no problem. Don't smoke and try and keep your weight down. Now, if you can do all of these and you have reasonable genes, then the likelihood is that you will stay fitter for longer than if you smoke and drink to excess and don't take any activity. So those would be my top tips. And I think see your doctor on occasion to have your blood pressure checked. Because that's an easy thing to remedy, and it becomes much more common as you get older for your blood pressure to go up.
Right. Well, I was going to ask about this. You mentioned about exercise and just keeping active, but we have in this country an obesity crisis, I think, and I wondered if that was the same in Europe, what you've seen.
It varies a little bit across Europe. I think the United Kingdom and Germany are not far behind the US with problems with weight, and the message still applies. I think people are not as active as they were, and they're taking in too many calories. And a lot of people are very sedentary during their working life, which means that they don't get the chance to burn off all these excess calories. And they tend to take a lot of empty calories, a lot of carbohydrate and sugar, which doesn't have a huge amount of nutritional value, I think is a major part of the difficulty.
So maybe, again, the diet comes into that as far as...
Sure, yes. I mean, a healthy diet, not too much, not too little, spread across the food groups. I don't go in for fatty diets particularly. I think just sensible eating is the thing to do.
In your work then, and while you're here, specifically, you're working with Dr. Wilkins, are you going to be seeing patients? Are you going into the hospital or out in the field, or how does that work?
So we do a variety of different things. They're mainly on the basis of teaching either students or residents and interns. So we are, so for instance, at some point during this week, I will be in St. Elizabeth's, and I'm also going up to Cleveland, and we'll also be doing some home visits and some visits to nursing homes. So the complete spread across the different possibilities. I know Dr. Wilkins is one of the few doctors in the area that does home visits, and I think he really enjoys them. Yeah,
we were talking with him a few months ago, and it's always fascinating. He was talking about some of his home visits, and I know, talking about food, he really enjoys when he's visiting, and he'll introduce some of his students to some do local cuisine, because the folks may have cooked something or baked something.
Absolutely,
yeah. Do you find do you do that also in Scotland? Are there home visits for doctors?
Yeah, there are. Many of our family doctors will do home visits. There is a difference. Hospital-based physicians are much less likely to be in the community than family doctors. That their base tends to be in the institution. So yes, we still, as a geriatrician, I still do these, but much less so than we used to. And the reason for that is that we have a community team, which I work with, which is a team of physical therapists, occupational therapists, nurses, dietitians, and so on, who I work with, and they tend to do the visiting, and then we sit down and discuss the case thereafter. So I meet with two of these teams on a weekly basis to discuss a kind of caseload that we have in the community.
Is there something similar here? Have you discovered that we do a team approach, or is it more scattered?
I think the team approach, which I've just described, is not uncommon in hospitals or in rehabilitation facilities. It's not that common within a community setting as far as I can see. And I think that comes down to the vagaries of how the process is reimbursed.
Right. Well, and you know, at some point we were going to bring this up, but could you describe, you're under National Health Service, and what that is? Here we hear terms like socialized medicine, which have, you know, connotations that, you know, politically people want to either, you know, push one way or they want to scare people. So why don't we just learn from you what exactly works over there, how it works?
So I think the first thing to say is I would never say that our system is perfect. So our system is essentially funded by taxation. So your healthcare services are funded and are free at the point of delivery. They're not free because you've paid for them through taxation, but they're free at the point of delivery, so you don't get big surprises in terms of bills. That means the downside of that is that although there is a baseline of care and it works reasonably well, it means it becomes a political football. So if the budget is constrained, then health, along with lots of other things like education, for instance, they're also constrained. So I guess the similarity for you would be your education system. Your education system is funded out of taxation. People don't necessarily expect to pay for that, although they can. It's a similar kind of process. Right.
If you go to public school, you would pay out of your taxes, and pretty much that's up front.
Yes.
One of the things that people are told is that, again, because Canada has a similar system, I guess, is that there may be waits. Do you find that a problem?
In recent years, it hasn't been much of a problem, but I think since the kind of crash in 2008, with a lot of issues around budgets and so on, it's becoming a little bit more of a problem. I think this is where the kind of political football bit comes in, because I think health is inexhaustible in terms of what people want and desire and so on. So rationing is part and parcel of the system, I guess. And I suppose that's got difficulties. However, I suppose to counter that, everyone's covered. I think the outcomes for the US system are really good, but only if you've got the ability to actually access the healthcare. So if you're in a job and you've got insurance and all the rest of it, that works. If you're not, then it doesn't.
Right. Well, and just from, you know, again, from personal experience, I just recently had a situation where I went to a doctor and was prescribed something, and then I get a call later within the day that the insurance company doesn't pay for that. So we have to talk to the doctor and, you know.
So that's not a system. I don't spend any time, if I write a prescription for someone, then I know that that will be filled. However, and there is a however, there will be certain drugs that need to be on a formulary, which is a list of drugs which are prescribable. So there are some similarities. So I wouldn't write you out a drug that I didn't know you would be able to get.
Right.
So on the other hand, particularly with cancer medications, there's new ones coming out all the time. They're extremely expensive. Then there's a balance of how you would how do you pay for that? I don't think any healthcare systems are perfect. I think the Commonwealth Fund in the US has just published I think it's a biannual, I can't remember how often they do it, but they have a look at 11 different healthcare systems. The UK came out quite well. The US has never done particularly well in the Commonwealth Fund research, and that's largely due to accessibility and cost. It's very costly, the American system.
Right. Well, and speaking of costs, one of the things that I've read about our system, and maybe it's similar in Europe, but the older adults tend to take up the vast majority of the resources. And what I mean, not necessarily older adults, but people say in the last stages of life.
Yeah.
Do you find that over there also? That
yeah. It's a universal thing, actually. The vast majority of healthcare expenditure is in the last 2 years of life, whenever that last 2 years of life is.
Right.
The likelihood is now in Western developed societies that your last 2 years of life are likely to be when you're older rather than when you're younger. And that's just a fact of life. So I would say, I think 2/3 of all hospital beds are occupied in the UK and in most of Western Europe by people over the age of 65, because they tend to be the ones who have an accumulation of ill health.
Right.
Now, it depends how you want to look at that. Is that a triumph or a defeat? So the fact that people are living longer, I would like to think, is actually good news, not bad news, but it's often painted as bad news.
Right. Well, and this gets into sort of a philosophical discussion about things like hospice, which I believe, did it start in Scotland?
London, I think. But
London, okay.
Yes, so it's a UK invention, yes, but it's widespread over the UK now. I think it was St Christopher's in London, I think it was, but yeah.
Well, it's become much more popular here, and it's in our area, but across the United States. But I think that's an example of where we're starting to come to grips with, everyone at some point will pass away.
Yes.
And what is that final journey like? Is it going to be in a hospital, or is it going to be more at home or somewhere else?
Yeah, I think there's this problem, isn't it, that what is it that people are looking for in life, which means also, what are they looking for in death? Now, is it life at any cost? Is it a good quality of life? Is it an appreciation that you can't have a pill for every ill? I think that's a difficult one, and it changes by culture.
Right.
So, was it Winston Churchill said that the United States and the United Kingdom were two countries divided by a common language? I think there is a certain sense that we think we are very similar, but in fact there are some cultural differences between the two countries that are maybe not always appreciated by people who cross between the two.
Well, we thank you for coming here, because if we all just stayed in our own culture and we never cross borders and never go to visit, we never learn about how things are doing over there. Speaking of which, is Dr. Wilkins also going to visit occasionally?
He hasn't been across to Britain for quite some time. I think I'll need to twist his arm.
Tell him I told him he should go.
Okay, I'll do that. Yeah.
Well, you mentioned about a pill for all ills. That made me think, again, in past work that I've done as an ombudsman, I've worked in long-term care facilities. One of the concerns I had was that people got a lot of medications, folks who were in some of these long-term care facilities. Is that something that you work with pharmacists?
Yeah, I think our routine is to review every 6 months what people are on, particularly if they're in a long-term facility, and try and decide what is the point of that medication. So if you are 98, is a statin to reduce your cholesterol, which may be causing you some muscle pain, really what you need?
Right.
And it's not going to do anything for your longevity. So I think that kind of decision is well worthwhile thinking about. And certainly when you talked about hospice care and palliative care in general, you should be on the least number of medications possible.
Mm-hmm. Although on the flip side, when you talk about hospice, that made me think of some of the pain medication. And we've had a real crisis here in the United States, in Ohio specifically, with the addiction. People are becoming addicted to the pain medication. Mm-hmm. Have you faced the same issues over there?
I don't think the addiction is a problem in hospice, certainly. I think we're quite careful about having what you call an analgesic ladder of starting off low and building up and doing it for a specific period of time. But I mean, one of the specific principles of hospice care is that nobody should be in pain, but you need to be quite skilled in using different types of analgesics and not leap to an opiate immediately. And they're not good for certain types of pain, actually, opiates.
Okay.
So it's a careful titration, I think.
Mm-hmm. Well, going back to the beginning of when you got started in medicine, what made it attractive to you to be a geriatrician? How'd you end up in that field?
Yeah, funnily enough, the Queen asked me that. I in a slightly different way, but I think I actually started off to be a family doctor, and part of my family doctor training, I rotated through a geriatric unit, and it was a professorial or academic geriatric unit. And these were very inspiring people, and there was also the chance to have both a foot in hospital and a foot in the community. And I really liked that juxtaposition of different things. So it was a combination of things. A, there was very good role models. B, the patients had interesting stories to tell. They were generally extremely interesting people with a history background behind it. And also that ability to both have a specialist focused but be a generalist, because these people had multiple issues that you needed a kind of overview for. So it's a really interesting, really academic specialty, which at that point a lot of folk like cardiologists and so on looked down on it. So for me, it was happenstance that I came into it, but it was the correct career decision for me, no doubt.
Well, it certainly worked out.
Yeah.
Do you try to convey that story to your trainees when you come through and talk about that? Yeah,
I mean, it's something we can be a bit evangelical, I think is probably the way to put it. Yeah.
Speaking of geriatrics, we have a large growth in the 85 plus population. That's the number one demographic growth. Are you seeing the same thing in Scotland?
Yeah.
And are we able to keep up with the demand for healthcare professionals?
I think we do have issues with healthcare professions right across the board. I'm not sure that working in healthcare is quite as attractive as it used to be. I don't think that's specifically around older people, but it's just a generality. There are other jobs which pay as well, if not better, and are not quite such hard work. So yes, there is a lack, I think, of that. We're not having any particular problem attracting doctors into our training programs, but our problem is that we are not quite meeting the need yet. So our training programs are, there are a specific number of places. So we fill the places, but we're forever expanding the numbers that we need, and we're just not quite in the catch-up process. So in terms of physicians, geriatric medicine is the largest single specialty in the UK.
Oh, it is?
Yeah.
Oh, okay. Yeah, I know from talking with Dr. Wilkins that there have been issues here, and maybe he's expressed that to you with trying to attract more geriatric.
Yeah, I mean, I think again it's a reimbursement problem here. I think so. In the UK, I would get paid the same salary as any other specialist, so that's not a detraction. Whereas here the fee per item of service process, I think, makes it a bit more difficult. Because there is no gerontoscope. You don't have a procedure you can do. It's very much cooperative with different groupings, and I think I certainly have come across that some things that I would treat slightly differently in the UK. They don't do that here because the reimbursement is more problematic.
Well, and we're in the middle of a debate about healthcare insurance here. And as you said, one of the problems in your mind is whether people have access. And so basically anything that keeps people away from being able to see a doctor is problematic, I guess.
Well, or any other healthcare professions. It doesn't always need to be a doctor, I think, is part of the issue perhaps. But I think accessibility to healthcare and being health literate, that's another issue. You need to know that you need to go, or otherwise you're going to miss that kind of problem. So health literacy is definitely an issue. But any lack of accessibility is going to be problematic for an isolated group, which many older people can be. Right.
Well, and we only have a couple minutes to go, but this made me think of a good practical question. If you're talking with a patient or a patient comes in and maybe their family member is with them, what are the best ways that they can help you? Should they come in maybe with some written questions, to communicate with their doctor better?
It depends on the circumstances, whether this is an acute problem or a chronic one. It's always good to think out beforehand what it is that troubles you most, and to try and focus on that a little bit. And try and get that over to your doctor as to what's the main issue that's bothering you, but not just that, what would better look like for you? Because better for some people is not better for others. And it depends on, many studies have shown that people over the age of 80, 2/3 of them, even although they have medical problems, still consider themselves to be in good health. So it's a balance of what you consider to be good health.
And just to go back to what you started with at the beginning about being not only physically well, but mentally and socially active.
Yes, absolutely. That's often very key. I mean, a lot of people, if they get socially isolated, that impinges upon their physical health and also their cognition and so on. So a lot of people get isolated if families move away and so on.
Well, while you're here, I don't know if you'll have time, but we do have the Austintown Senior Center up the road, so that's something that I was involved with to try to get people out, older adults, and I imagine you probably have similar things back in Scotland there. Yeah. Well, thank you very much. We've been talking with Professor Paul Knight. He is a new OBE, which is the highest, well, one of the highest honors you can get in Great Britain and Scotland. He's from Glasgow, Scotland. He's here visiting Dr. Wilkins, who is from St. E's, works down at St. E's. Thank you very much for coming on.
Thanks.
And we look forward to seeing you next year or whenever you want to come back.
You never know.
Again, you've been watching Senior Focus. I'm Bill Adams, your host. Thanks to Greg Roten from Armstrong Cable. And also thanks to the Youngstown Public Library System for their use of the library. If you missed any of the show, you can always go to On Demand on Armstrong or go to YouTube where the shows are archived. You could just type in Senior Focus and Armstrong Cable to find Senior Focus. Until next time, thanks for watching.